This time I'd like to introduce our keynote speaker, Dr. Robert Drake. Bob has held a number of leadership positions in his 40-year career, and is currently the professor of health policy and clinical practice at the School of Medicine at Dartmouth. And he's also the vice president for social policy and economics research at the Westat Corporation. Over the past 4 decades, Bob has been one of the most influential leaders nationally and also internationally in public services for people with severe mental illness. After earning his PhD and MD degrees from Duke University, he has served as the principal investigator or co-principal investigator on over 80 federal or foundation grants, and he's published over 650 articles and books. These endeavors have positively shaped the mental health knowledge, practice, and policy. His own past research includes groundbreaking research and development on the evidence-based practices of assertive community treatment, integrated dual disorder treatment, and especially the individual placement and support IPS, an effective model of supported employment that he co-developed along with Deborah Becker. Bob has also been the leading figure in ushering evidence-based practices into mental health. And this includes his work as a PI on grants from the Robert Wood Johnson and also from SAMHSA, which helped implement evidence-based practices in routine mental health settings, and in developing the federal evidence-based toolkits that have been widely disseminated not only through the United States, but internationally. Bob's work goes well beyond research, however. He's also a passionate spokesperson in collaboration with persons with lived experience in person-centered values and the recovery movement as a cornerstone of mental health policy. I've had the privilege of knowing Bob for about 30 years as a professional and as a friend. And perhaps most striking to me, in addition to his extensive contributions to the field, is the manner in which he goes about his work. A style that is characterized not only by thoughtfulness, intelligence, and dedication, but also by humanistic values, good-naturedness, humor, humility, and most of all, a steadfast caring for the rights and well-being of people with mental health disorder. I think it's no accident that as busy as Bob is, he still finds time to volunteer at a shelter in Vermont. So without further ado, it is my great privilege to introduce my colleague and friend, Dr. Bob Drake. Bob, we're so glad you're here with us today.
Oh, thank you. Thanks very much. So I'll see if I can, this is about the peak of my IT expertise to be able to share my screen, which Kara just taught me before this. I'm really pleased to be here with you folks today, and I'm delighted to hear about the evidence-based practice center that you're building. You know, Gary's over-the-top introduction should be tempered. You know, the truth is, you know, I come from a family with lots of mental illness, and I consider myself a person in recovery. And so for 70 years, I've been trying to figure out how to improve care with only very limited success, but I'm still working at it. And today, what I'd like to do is to talk a little bit about recovery and then talk a little bit about evidence-based medicine and what that means and how these two fields can come together to help us develop a system of care that uses both to the best extent we can. Now, let's see if I can advance this. How do I advance the slides?
So push from the beginning.
From the beginning, okay, there we go. Okay, so maybe this is gonna work.
Oh, push,
So,
push it in, up in that, your top left corner.
yeah, I
Yeah,
thought I did push that. Oh, okay,
there you go.
great, okay.
Got it.
So, let's see. So Gary Morse is one of my favorite people in the field, but another is Pat Deegan, whom I think you must all know because of her great work in mental health advocacy over many, many decades. And Pat is great about telling her story, and it really says a lot about the things that we want to talk about today. You know, as an adolescent, Pat was hospitalized with psychotic illness that was labeled schizophrenia. And she struggled for a couple of years in and out of the hospital. And then she says she reached a point where she didn't go to the hospital anymore. But what she was doing was sitting in her rocking chair at home, smoking cigarettes and watching TV all day. And her psychiatrist said, well, you're a real success now because you're not going to the hospital. But Pat's view was that she wanted a lot more in her life than rocking and smoking, and she didn't consider this a success at all. And so she proceeded to do a number of things. She cut down her medicines drastically. She went back to school, ended up getting a college degree and getting a PhD in psychology. She developed a number of programs for wellness. Many of you probably know her Hearing Voices program, her personal medicine program, her Common Ground program, her Recovery Library program, all of which I consider brilliant advances in thinking about treatment and recovery. And in addition to doing all of that work, she got married. She and her spouse adopted a child, and she's just a wonderful wife and mother, as well as a great success in her business. And Pat's really responsible for a lot of what we know about recovery and for a lot of the interventions that have been developed that I'm going to try to talk about. So I'll say a few words about the community mental health movement, but then I really want to talk about recovery-oriented practices, evidence-based practices, and system change that might move us towards adopting those practices more completely. All right, so briefly, you folks know that the community mental health movement really started in conjunction with deinstitutionalization and the Community Mental Health Act in the early 1960s. And one of the problems from the beginning, which we're still struggling to overcome, is that there's been little attention throughout this history to clients' personal preferences about what kinds of services they want and what kinds of outcomes they want. Instead, our system has been driven and developed by professionals, by industry, especially the pharmaceutical industry, by top-down government decisions, and by a variety of vested interests, you know, like hospital associations, and American Psychiatric Association, and so on. And many of the interventions that have been developed and disseminated around the country as a result of this history have been, you know, ineffective and even harmful. I'm going to return several times to this theme in my talk, but let me just tell you my personal history is that, you know, I was trained at Cambridge Hospital in Boston, and it was a very exciting time in deinstitutionalization, and we were, I was involved in starting the first ACT programs in Boston, which was very exciting. But most of what I learned in training, you know, was based on the expertise or the expert interests of the faculty at that time. And it turns out most of these interventions, and I'm thinking about rapid neuroleptization and Tavistock groups and paradoxical interventions with families and psychoanalysis and on and on and on. Most of these interventions were considered outdated within 10 years. And about 20 years after my training, most of them were considered malpractice, and you could be sued for doing these things. So I tell all the residents and other trainees here that what they really need to learn during training, and I believe this strongly, is how to keep up with things, how to acquire information, and how to change. Mental health is a very primitive field. A lot of what we believe is true turns out to be not correct, and our knowledge base is just expanding rapidly. Okay, so all of this has been helped by the consumer movement, the recovery movement, the evidence-based medicine movement, shared decision-making movement, and the movement towards preferences. And I'll say something about each of these, but let me start with recovery. I've done several reviews of the recovery literature over the years, and it's interesting to me how it gets defined by different groups. People who have actually been involved in their own recoveries talk about this, and this comes from a synthesis by Rob Whitley at McGill. People talk about it as a journey of small steps with a growing sense of really being in charge of their own recovery. They talk about it as a personal and subjective experience. They talk about it in terms of developing relationships, developing a sense of meaning, developing participation in their community. And they talk about the role of the mental health system as being humane, needing to be humane and empowering, but that's not typically what they've experienced. And from the early stages of the recovery movement, I would say in the early 90s, it's to a large extent been co-opted by professionals. People who wrote about recovery in terms of Rogerian psychology and therapy, in terms of social skills training, in terms of skills training in day treatment, in terms of sheltered stepwise jobs, and on and on. And I consider motivational interviewing in this category because motivational interviewing is really based on a process that assumes that the interviewer knows best what you should be doing. And all of these attempts to co-opt recovery are really paternalism, reinvented in one way or another. Our system of mental health continues to be extremely paternalistic. And I could give you many, 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 many examples of this if you're not convinced. And then there's industry's attempt to take over the recovery movement. In the last 30 or 40 years, industry has come up with one, breakthrough, so-called after another. And, we've been through the new medication movement. We've been through the decade of the brain. We've been through the decade of the genome, and so on and so on. All of these, I believe, are based on the false paradigm that there are some specific brain impairments that define specific illnesses that we can diagnose, which lead to specific medications that treat these specific brain impairments and diagnoses. And, there's really no evidence for this. again and again, we discover that, the brain is much more complicated than we are so far able to figure out. There are hundreds and hundreds of genes and experiences during pregnancy and experiences in early life and assaults in development and adult life that lead to the kinds of syndromes that we tend to call diagnoses. And there's just no evidence that there are specific treatments for any of these either. As a psychiatrist, I have been impressed that we are now still where we were back in the 70s when I was first studying this, and that is kind of empirical trials. Let's give somebody a trial of this, and then if it doesn't work, we'll try a different class of medication. It really hasn't advanced very much, and if you are not a believer in what I'm saying, you might read the lovely book by Anne Harrington, history of science professor at Harvard, called The Mind Fixers, where she describes in detail these cycles of failure of the biological psychiatry movement. And then researchers, have also tried to look at recovery. And of course, as researchers, I put myself in this category, we always want to be able to measure something. Talking about ethereal concepts that can't be measured is really not something that research can help with. And so we want to measure things. And in general, the recovery, as much as we have lots and lots of measures now and thousands of studies trying to quantify recovery, statistically, it breaks down into these three categories. There's clinical recovery, where we talk about people's symptoms and ability to manage their illnesses. There's social recovery, where we talk about people's functioning in the community. Are people able to have friends, participate in education and employment, participate as citizens in the community, and so on. And then there's personal recovery, which has to do with the psychology of people in recovery. That is, defining their sense of self, improving their self-esteem, improving their sense of agency in dealing with the world, in dealing with the healthcare system. Okay. Lots of people write about recovery processes, and they tend to focus on the same things I just mentioned, relationships, including relationships with treatment providers, as well as family and friends and people in the community. This sense of meaning and participating in normalized or regular roles in the community. Okay. There's a fellow named Mike Slade in England who spent years trying to define recovery and recovery interventions and so on. And Mike lists 10 interventions that he believes are recovery oriented and strongly supported by research evidence. There is the movement to hire peer support workers, within or next to the treatment system. There's the development of advanced directives that allows people to specify ahead of time what they would like to have happen if they experience another episode of psychosis or severe depression. And has definitely I would say that, first of all, the peer support movement has been extremely helpful in the settings where I've worked, because it changes the milieu and level of conversation and respect and dignity. The advanced directives seem to be helpful because they decrease the need for compulsory or the use of compulsory treatments. There's the next intervention is wellness recovery action planning, which is helping people to define their own plan for recovery. And it's really a lot like Pat Deegan's personal medicine plan. There's the illness management and recovery movement that my colleague Kim Musser has advanced over the last decades. It really combines 5 evidence-based practices, including cognitive behavioral treatment, relapse prevention interventions, psychoeducation, and so on. And then there's an intervention called Refocus, which I think is more common in Europe than in America, but it's a manualized intervention for treatment teams in which they spend time talking with each other about how to develop person-centered planning, how to use clients' preferences, and how to promote active goal striving. I've not worked in that model, but it sounds interesting. And then there's the strengths model that many of us have tried to incorporate in assertive community treatment and other interventions. That was strongly promoted for years by Charlie Rapp and his colleagues in Kansas, and so you're probably extremely familiar with that in St. Louis. And then the final interventions that Mike Slade identifies are recovery colleges, which I think are relatively new in the US, but are used more in Canada. And I like this idea because I've always thought that the education about mental illness and about coping with mental illness ought to be in colleges, community colleges, and so on, rather than in the mental health center. And people ought to get credits for taking these courses and learning this information. And then there's the supported employment movement and IPS that I've worked on for a few years. There's the supported housing movement, which tries to give people choices and control and safe housing, and it's been a great advance. Another one that works extremely well, like supported employment, except that we just don't provide much of it in the US. And then finally, there's another European movement called the Mental Health Trialogue, which is an attempt to establish forums for discussion with the public and to tackle stigma busting head on. And I think we don't do much of this in the US, but we probably should. Okay, now let me switch over and talk for a few minutes about the evidence-based practices movement, or evidence-based medicine. This evolved in Canada and the UK decades ago. And it's really based on trying to bring evidence into decision-making in medical care. It assumes that there are these 3 pillars or legs of the stool, good science, attention to clients' values and preferences, and clinical experience of the provider. And most important, it's to find a hierarchy of evidence so that we really, and in this hierarchy, which is often presented as a pyramid, expert opinion is right at the bottom. And that's because it's unreliable and it's often wrong over time. But we continue to rely on it way, 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 way too much, I think, in our policy making and in our decision making. And then on top of expert opinion, things get more and more reliable and evidence-based, you know, as you go to observational studies and randomized controlled trials and systematic reviews and meta-analyses and so on. And, you know, the Cochrane Collaborative in the UK has really been the leading organization in trying to provide these kinds of evidence-based reviews of all medical care, including mental health care. It's great that evidence-based medicine really specifies that clients are the experts about their own experience. You know, I mean, we know from lots and lots of studies, for example, that the medications we're always pushing, the antipsychotics and the antidepressants, for example, are only effective for about 60% of people. Well, clients know that also, and they don't want to take the medicines when they're not helping them. We continue to think that medication compliance is next to godliness in this country, but it's just not true. And we need to rely on clients to, you know, be the arbiters of what's effective and what is causing more side effects and so on. You know, clinical experience is also important. And I think as we present shared decision-making tools to people, you know, which we should all be doing, and the preference laboratory at Dartmouth has developed hundreds of these tools. And what they do is to lay out in very simple terms, what are the alternative interventions for a specific condition, and what do we know about the advantages and the disadvantages or harms of these different tools. And the idea is that the clinician and client look at this as as sort of a map of what the possibilities are, and the client knows about his or her experience with these interventions, and the clinician knows something about his or her experiences with the interventions. And together they make a shared decision making. And I really want to emphasize here that shared decision making is different from motivational interviewing. In motivational interviewing, we're assuming that the clinician knows what's best for the client, and the intervention is based on manipulating the client's ambivalence about an intervention or about an outcome. Shared decision-making doesn't make that paternalistic assumption. It instead says, let's lay out the evidence as much as we can and think about it together and try to come to a shared decision. Okay. There are lots of evidence-based mental health practices as well as medical practices. You know, these are standardized interventions that are defined by manuals and measured by fidelity scales. They're based on controlled research or randomized controlled trials. We insist on more than one research group, you know, being involved in these randomized controlled trials because people are biased about the interventions that they like or they've developed. They're based on objective outcome measures so that they can be repeated across studies, and they aim at meaningful outcomes. And this is really important because, you know, for many years in medicine, we have developed interventions and aimed at things that are really correlates of meaningful interventions. You know, there are second order or even third order correlates. For example, medication compliance. You know, medication compliance is not a meaningful outcome. Actually, feeling better is a meaningful outcome, and medication compliance is only partially related to that. And as I said before, for many people, medications don't work, and so medication compliance is actually a harmful intervention. Okay. Here are some of the practices that are commonly identified and have very strong evidence: assertive community treatment, supported employment, supported housing, psychoeducation, and you know, and now suddenly America believes it's discovered early psychosis interventions, even though they've been well established in Australia and some European countries for 30 years now. Let me talk for a minute about IPS supported employment. It's the intervention I know best, and I think it's the best exemplar of a recovery and evidence-based intervention. IPS has been developed by Debbie Becker by talking directly with consumers about what they want and what works for them. It's available to anybody who wants to work. It helps people with competitive employment because that's what they want. It offers a rapid job search because most consumers hate all of these lengthy evaluations and practice sessions. The employment specialist helps to develop a job and with a targeted job development. You know, if somebody wants to work with animals, well, we need to talk to veterinarians and pet stores and farms. We don't need to be talking to grocery stores to develop a job. Everything's based on client preferences for when to go to work, how much to work, where to work, and so on. Individualized supports are developed by the client in terms of what they think they need. The vocational services are integrated with treatment so that we can be sure the treatment people are on the same page and offering the same advice. You know, I can't tell you how many clients I've heard say, well, you know, I thought I wasn't supposed to go to work, but then when my doctor told me I could go to work, I was ready to get a job right away. Well, it's just a crime that we doctors have been telling people that they couldn't work for so much time. And IPS tries to make sure people get good benefits counseling so that they know what will happen to their benefits when they go to work. Okay. There are 28 randomized controlled trials of IPS. All of them show that it's better than a variety, every comparator that's been examined, you know, so there is not an evidence base like this for most interventions, but there should be if we really had data-based and evidence-based systems. IPS is a recovery intervention, I think, because, you know, it's totally based on clients' choices and clients' goals and helping people to find employment that doesn't just increase their income, not just a job, but a job that fits who they are and provides the structure and self-esteem and community integration that they want in life. And IPS has spread around the country, not because of federal support. You know, the CMS continues to fail to help fund the service. And so for most mental health centers, it's a money loser, but something they provide anyway because it's so important to recovery. And one of the things that's helped the spread and development and research of IPS is the learning community, which I encourage you folks in your evidence-based practices center to use. And we can talk about that more later if you'd like. Now let's switch over. In the last few minutes, I want to talk about developing a recovery system and recovery evidence-based system. But the recovery part of the system, you know, needs to support people's individual ideas about their personal recovery. It needs to provide relationships that are based on, you know, respect and dignity and mutuality and so on, which we haven't done during most of the years I've been in the mental health system. It needs to have a huge organizational commitment. And we're far, far from this in the US now. which I'll explain. And it needs to address the public and needs to address the constant media attention that promotes stigma in our society. And again, I think we're far, far, far from doing this so far. So the American mental health system is amazingly far from this kind of recovery evidence-based system. You know, what those of us who study health services are constantly faced with the paradox about American healthcare. And that is that we spend more on healthcare than any of the other 40 high-income countries in the world. And our outcomes are consistently at the bottom or near the bottom. And so we have to be thinking about constantly, how is it that we spend so much money and we get such lousy outcomes? And the lousy outcomes extend across all of medical care. Virtually everything that's been looked at, we have poor outcomes compared to other high-income countries. And why this happens, some researchers have identified, well, we put a lot more money into pharmaceuticals, we put a lot more money into high-tech interventions like imaging, we pay a lot more for doctors, we pay a lot more for hospitals, but essentially, all of these things are based on top-down policies that are determined by government, by professional organizations and guilds, by the extremely toxic effects of the pharmaceutical industry, and by all of the vested interests that control our healthcare system. And I'm sorry if that offends a lot of people, but I believe that's the reality in the United States. We continue to finance non-evidence-based practices, redundant medications, and non-recovery oriented services. And we actually pay very little proportionally for the recovery-oriented services that consumers actually want and need. I talked to you a bit about my own training and my recognition early on that clinical wisdom is often just wrong. It's not what we should be developing our system on. And yet I see out around the country, lots of these folks who make a living by providing expert opinion and expert advice to states and to mental health systems. And they are way behind the times typically because the evidence is developing faster and faster, even though there's still long delays in implementing evidence-based practices, we're developing new evidence. If those of you who have followed carefully what we've learned during the COVID pandemic are very aware of this. It's just amazing to me that we learn new things about RNA viruses almost every day scientifically. I think all of this understanding is probably, some of it is involved in the incredibly rapid pace of developing vaccines, but after this pandemic is under control, we will know thousands of times more about viral illnesses and RNA illnesses than we did before the COVID pandemic. And we'll need to be thinking about how to incorporate that into the way we care for infectious disease. We are also, by the way, just learning amazing things about the immunologic system and how it works and how it responds to viruses that should affect care dramatically in the near term future. So how would we develop a recovery evidence-based system in mental health? Well, there are a few things that we know we need to do. You know, one is to start with values, that we really want to be helping people achieve the kind of relationships with providers that they want, and we want to be helping people to achieve the kinds of outcomes they want. We can't be, you know, continuing to send the police out for a mental health crisis. We can't be continuing to house people in jails because there are not enough hospital beds available and they didn't get the prevention services that would have prevented the crisis way before it happened. We need to be working towards the kind of humane and empowering mental health system that Rob Whitley has been talking about for decades. And this is going to require widespread systemic changes to fund the kinds of services and the kinds of choice processes and the kinds of goals that people who use the system have. And there needs to be an enormous organizational commitment to this process. I mean, it's a wonderful thing that SAMHSA kind of tries to promote these good values, but SAMHSA doesn't have much money. SAMHSA doesn't control the system the way pharma does, or the way that CMS does, or the way that states do. And we need to get through to the funders in order to institute real and lasting changes. And if we could do this, I believe the focus of consumers, as well as the focus of science, pushes us towards looking more and more at social determinants. You know, we don't get lousy outcomes in the US simply because we misspend money on healthcare. We also get lousy outcomes because we don't pay attention to social determinants, and we don't pay attention to the social services that should be integrated in our health system. You know, people need food and financial security. They need safe housing, meaningful relationships, or meaningful activities and supportive relationships. And if they have those things, they're not going to spend their time having mental health crises and going to emergency rooms and waiting in emergency rooms for days for a hospital bed. And more than developing an entirely new crisis care system, which I know SAMHSA has been sponsoring, we need to go back and focus on these social determinants so that we're preventing crises rather than, you know, it's the American way is to medicalize everything and provide more and more medical care for services and conditions that could be prevented. We need to focus on prevention and on social determinants. And when we get to funding actual services, you know, we need to focus on clients' goals. So a recovery-oriented, evidence-based system would dramatically change funding. You know, the funding for pharmaceuticals in this country, which is already just gigantic compared to any other country, just keeps going up logarithmically. It grows and grows at a pace that's totally not justified by the science. And we need to change who's controlling the decisions that are leading to this, you know, misuse of funds. We need to change the options that clients coming into our system actually have. We need to focus on the goals that are important to them. You know, we got involved in studying supported employment because the director of mental health in New Hampshire came to us at Dartmouth and said, look, could you help us with something Every year we do a survey of clients, and every year they say the number one thing they want from the mental health system is jobs. And we do nothing to provide jobs. We don't know how to help them find jobs. And that's how we got started studying different employment systems. And by the way, the first thing that we found out in doing initial studies was that all the expert opinions that we got from the so-called gurus about psychiatric rehabilitation were just wrong. You know, we're just wrong. It didn't take 9 months of therapy to help somebody figure out what kind of job they wanted. Most people, over 90%, knew what kind of job they wanted immediately. It didn't take 6 months of skills training to help them get ready for a job. It didn't, and on and on. But we still need to change, you know, our attitudes about these things, because, you know, everywhere I go, I still see systems that are based on the idea that we know best what people need, and we don't need to listen to what they think they need. Our systems are still terribly paternalistic. You know, I've gotten hammered by professional organizations and the medical school and so on when I give talks about how medications work, because essentially what these experts say is, well, you don't really want to tell patients and their families the truth about how these drugs work and what we know about them. They might stop taking their medications if they really know the truth. Well, you know, that's a horrible attitude for us to be promoting. We need to work with consumers and family members in order to do what they call co-production of health and recovery, you know, planning these systems together. And I think the best way to do this is by providing or starting learning communities that include all of the stakeholders in figuring out, what do we need to do next? What do people want? What's the problem in the system? I've been so impressed watching the IPS learning community from the outside. You know, they will, you know, the people who are involved on the ground know what's really going on. They came to us and said, look, you know, we have this big problem now that so many people in the mental health system have a criminal justice history, and they're being screened out of jobs. How can we work around that? And so it only took a few studies to figure out how to work around that now. And it's part of the basic training for IPS employment specialists now. But that didn't come from the experts. It didn't come from government. It didn't come from the pharmaceutical industry. It came from clients and employment specialists on the ground. So I encourage you with your new center to be thinking about taking this approach to learning communities, setting up learning communities among practitioners, and setting up learning systems within your state too. You know, learning systems should be collecting data, looking at doing small experiments all the time, so that we know better what we should be doing and what people want and what's effective. It's always amazed me that, you know, and I consult with about 30 states. It's always amazed me that they're trying to run these big systems without good data, but they haven't had good data because they haven't collected good data. You know, when I worked for the state of New Hampshire, it always amazed me how easy it was to do a small survey across the state, and how surprised the state mental health authority was to see the data. They had no idea what was really going on in their system. Well, we should be able to change that pretty easily. We should be able to develop, you know, learning communities and learning systems of care. So I'm going to stop at this point, but what I've tried to argue for is that we develop a new paradigm in the mental health system. And this paradigm should value users rather than industries and vested interests. It should include the users in conceptualizing the system, studying the system, designing, redesigning the system, implementing interventions, delivering interventions, monitoring interventions, and constantly revising our policies as the evidence changes rapidly. And in order to do this, to develop this kind of new paradigm, this new system, we're going to have to figure out how to shift funding. We can't continue to send most of the mental health budget to the pharmaceutical industry without insisting on any real return on our investment. And how to do that politically, I don't know, but that's the challenge ahead of us. Okay, so I'm a researcher and I am required to disclose my funding sources. And I've been fortunate over the years to be funded by a lot of great institutions and a lot of great foundations, which are mostly family driven foundations. So here's the list. I appreciate what these folks have helped us to do. The kinds of things I've talked about, I hope are all based on good evidence. If you would like research articles, please call or write to Susan Morris, our wonderful, wonderful administrative assistant here, and she will send you what we think is the best evidence for any of the things that I've argued for. So thank you very much again for inviting me. I hope I haven't offended everyone with my iconoclasm. I know that I do that sometimes, but I believe strongly that if we can, really keep our eyes on recovery and on the evidence base, we can create a much, much, much better, healthier, more functional mental health system. I'll stop here.
Well, Bob, thank you so much for sharing your years of experience in terms of recovery. And I'll just personally say that I was not offended at all. And I really like much of what you said. It gives us much to pause and think about. I would also like to ask all of our participants at this point to give Dr. Drake a warm Missouri thank you virtually for him taking the time with us this morning.
Well, it's my pleasure.
All right.